probably you may have heard this presentation before, but that's okay. It's okay to hear it again because the situation changes, right? So maybe what your situation looked like a year ago, it may look different now. And that's one of the things we're going to talk about with these challenging behaviors is that they come and go and they change. So sometimes people describe it as addressing these challenging behaviors as a bit of a moving target, because what works one day may not work the next day, and the challenge you're facing one day may be completely different than the next day. So that's perfectly all right. I'm glad to see some return attendees. So as Jennifer mentioned, I'm an occupational therapist, and I've been a clinician for about 21 years now, primarily working with older adults. So in a variety of conditions, post stroke and Parkinson's disease, and certainly dementia. A few years back, I really became disenchanted with what I was seeing in terms of care of persons with dementia, really in facilities. I just was not, I felt like there was a lot of, put somebody in the wheelchair and put them in front of the TV. And I just wasn't happy about that. I started really thinking about how do I fix this? What do I do about this? And the logical step was to further my education. So I went back and pursued a doctorate, and I received that back in 2019. I was hired here at the university back in 2018 to work with the Biggs Institute. And then I was very fortunate to be picked up by the Caring for the Caregiver program as well. So since then, I've really, devoted all of my research and all of my clinical efforts to this. How do we help you guys? Medication can be helpful, but it's not the solution. So what else can we do? And, by and large, as an occupational therapist, people come to us and say, well, how do we, I can't get my loved one to do things anymore, or how do I help my loved one? So a lot of times the challenges are due to behaviors, what we call behaviors. So we're going to talk about some strategies today and some things that we can do. But I really want to focus a lot too on why these behaviors are happening. That's really kind of the core. If we can get to that, if we can figure out why it's happening, then we can start to come up with some solutions. So as Jennifer mentioned, I'm the primary clinician for the COPE program, and I'll skim through this. She already kind of touched on it. It's a home-based program for persons living with dementia in the community and their care partners. So the participants receive a series of 5 to 10 visits by an occupational therapist and also by a nurse. So we also kind of look at that medical piece as well to make sure, are there issues with medication management? Do the caregivers know signs of urinary tract infections and how to look at skin integrity and things like that? So it's a fairly comprehensive program. The visits are designed to occur in the home. COVID obviously changed that. So we did shift to a virtual format, and we've been doing it virtually since the onset of COVID. So we're collecting some interesting data about, can we do that? Can we actually make a difference doing this virtually? If we find that we can, that's actually pretty exciting, because that means we can reach some homes otherwise we may not be able to reach. So we are still continuing with that completely virtually. So quickly, I want to review the different types of dementia. It's very, very important that we have a differential diagnosis. Dementia is this big umbrella term, and under that umbrella, we have a lot of different types of dementia. Well, it's really important that we know which one. That kind of guides our intervention. It also helps us anticipate the types of symptoms we may see. So Alzheimer's disease is the most common. It accounts for 60 to 80% of cases. So a person living with Alzheimer's disease may have difficulty with memory, communication, judgment. We may see these behaviors and orientation. There is a progressive loss of function, and you may see a lot of apathy and depression. So you may see just a lot of the person loses complete interest in doing much of anything. The next one is frontotemporal dementia, often just referred to as FTD. So this is a lot of times an earlier onset. So the person may have an onset in their 50s to 60s. And the first thing noticed is usually changes in behaviors. So that person might start, presenting with some erratic behaviors or some very spontaneous behaviors. So it doesn't always occur to somebody that this might be a dementia. It just, why is this person acting like this all of a sudden? Why are they spending money and, things like that? For a person with FTD, memory is often preserved. So that can, again, the person may not always think dementia. Lewy body disease, this is a very, I say it's increasing in the prevalence. I don't know if that's true or if we recognize it more. I can tell you 15 years ago in practice, we never saw this diagnosis. So I think it's probably more recognition and more prevalence of diagnosis as opposed to prevalence of existence. I don't know. But with Lewy body disease, we see an impairment of executive function. So those higher level thinking skills, things like, that reasoning and that problem solving. One of the hallmarks of Lewy body disease are visual hallucinations. So that's typically accompanies Lewy body disease. Something else that accompanies Lewy body disease are what we call visual perceptual dysfunction. So it's not that their eyes don't work, it's that the part of their brain that interprets those images, that part doesn't work so well anymore. So a lot of times this is maybe the person that, the loved one will say, my husband, he trips over everything and he can't see things that are sitting right in front of him, but the optometrist has checked his eyes 10 times and they say his eyes are fine. Well, that's because the problem is not with the eyes, the problem is with the brain. So that, again, that really looks like that they just don't see things that are right in front of them, or they may trip and fall a lot because that depth perception just isn't there anymore. With Lewy body disease, we also see a motor dysfunction, and this looks very similar to Parkinson's disease. So in fact, from a perspective of what this looks like in the brain, Lewy body disease and Parkinson's disease with dementia look very similar in the brain. So a lot of times the diagnosis is made depending on if the movement disorder comes first, it tends to be diagnosed as Parkinson's, and then later Parkinson's with dementia. If that dementia piece comes first and then the movement part comes later, it's diagnosed as Lewy body. But essentially, they're the same thing. Now, not to be confused, not everybody with Parkinson's will develop dementia. So this is for people with Parkinson's with dementia. Then we have vascular dementia. So that includes like multi-infarct dementia. So this is a person who's just having a lot of strokes. It could be major strokes, and it could be just small strokes that are constantly happening. So they may show impaired judgment and decision making. Again, their memory may or may not be affected. It depends on where those strokes are happening. The challenging thing about vascular dementia is it's not very predictable because it all depends on where those strokes are happening. So this is the second most common neurocognitive disorder. Okay, and then briefly some other types of dementia. Korsakoff syndrome is typically related to substance abuse. Prion disease is a very rapidly progressing form of dementia. Parkinson's disease, again, as I mentioned a while ago, can be accompanied by dementia. Huntington's disease. Sometimes we'll have a diagnosis of mixed dementia. Maybe somebody has Alzheimer's, but then they've had a series of strokes as well. So then we may have Alzheimer's, but we also have vascular dementia. And then what we don't like to see is unspecified. So that makes it challenging. So if we have that, then we really want to try to get into the Biggs Institute or get in to see some specialists so that we can get that differential diagnosis. Oops. Okay, so next we're going to talk about symptoms of Alzheimer's disease and related dementia. So collectively, we call all of these ADRD, which again is Alzheimer's disease and related dementias. So we're going to kind of lump them into two categories today. We're going to lump them into the cognitive symptoms and the non-cognitive symptoms. So when we talk about cognitive, those are the thinking issues. Those are the things like memory and the ability to learn new material. That short-term memory, I just told you where we're going. Why are you asking me again? I literally told you 5 seconds ago. That short-term memory. And then that executive function. So again, that ability to problem solve and to take information and utilize it and manipulate it, some of those higher level functions. Then we have this whole list of non-cognitive symptoms. So these are the things that we tend to term as behaviors. So like physical aggression and restlessness and agitation and wondering and culturally or sexually inappropriate behaviors, hoarding, shadowing or following the caregiver around, sometimes even cursing. Maybe the person has never done that in their entire lives, and now all of a sudden there's a lot of foul language coming out. Hallucinations or responses to hallucinations. This is not a comprehensive list. These are some examples. There are a lot of different non-cognitive symptoms of dementia. So collectively, we're going to lump those together, and we're going to call those behavioral and psychological symptoms of dementia, or BPSD. We're going to kind of lump all those things together. So how do we know somebody is experiencing BPSD? Well, these are evaluated based on observation and caregiver reports. So there's no test for this other than it's happening. Okay, therefore it exists, right? Unfortunately, they're unpredictable and they're inconsistent. So a person with dementia may be fine one day, and then the next day we see all these behaviors happening. Or it may be more like, over the last 6 months, things have been really good, and now all of a sudden we have all these behaviors and we're not sure why. The flip can also happen. They can suddenly change or stop. So it's very inconsistent, and there's no way to predict it. We can't say, okay, your loved one is at this stage of Alzheimer's disease, so these behaviors are going to happen. It doesn't work like that, unfortunately. It's very unpredictable. These can occur at any stage of dementia. They can occur early, they can occur late, or any time in the middle. But they affect up to 90% of persons with dementia at some stage. So at some point, you're going to probably deal with some type of BPSD. So this slide probably goes without saying, there is an impact on caregivers. So I saw that, Cindy. Obviously there is an impact on caregivers, right? So caregiving for a person with dementia can have a negative impact on the caregiver's physical and mental health. This is very well documented. So according to this study, caregivers of persons with dementia with BPSD actually have higher mortality rates. So this BPSD can be one of the most stressful things that caregivers encounter. So we really need to look at how we can help with this. So what do we want to look at? Okay, why is this happening? Why do these behaviors occur? And this is just a nice slide. This isn't necessarily specific to behaviors, but it's just a nice slide, to show how over here on the right side, we have a typical brain. And then over here on the left side, you see this atrophy. You see where we just have these holes now. And and you can see up here in this frontal lobe where we just have all this atrophy. So literally we have shrinkage of the brain. And we're not going to get too much into that today, but it's just a nice graphic to show you how those significant changes are happening in their brain. So, okay, why do challenging behaviors occur? All right, here's our theory. So I want you to follow me through this theory. Okay, as the function of the brain becomes more impacted, so they're having more and more impact, more and more atrophy of their brain, individuals with dementia experience more difficulty understanding their environment. Things in the environment just don't make sense anymore. Okay, as their language abilities decline, it is more difficult for individuals with dementia to verbally express their needs and concerns. So things aren't making sense, they can't communicate as well. All right, so if we assume that environmental factors shape behaviors, so their frustration with the environment and their difficulty communicating can sometimes shape those behaviors, then it stands to reason that we can change or affect their behavior if we change the environment. So if we affect the environment. So that's really good news for us as caregivers, because we can do that. We have the ability to change and affect the environment. So that's what we're going to learn about today. How do we do that? We can't change their brain, right? We cannot go in and fix their brain. Everybody at the Biggs Institute, they are working on that. At some point they will figure that out. We're not there yet. So what can we do? We can modify the environment. So we need to look at what are some of the triggers of these behavioral symptoms. What's causing them to happen? This is specific to your loved one. This is part of what you have to do as this detective trying to figure out what can I do about this. You want to try to figure out what's causing it. Where did this come from? So we want to look at things like, are they in pain? Again, remember, if they're not able to communicate as well, maybe they're not able to communicate that pain. So maybe they're hurting. And, if they've got a bad knee or a bad back, it's probably a fairly safe assumption that, yeah, if the weather changes, they're probably in pain. But what about things like constipation or urinary tract infections? Some of those things that your loved one may not be able to identify and tell you that. They just know something's not right. Are they fatigued? Are they just flat out tired? We would expect that these behaviors might exacerbate if they're really tired. Are they afraid? For a person with Lewy body dementia, if they're having very scary hallucinations, they might just be afraid. Or if you as the caregiver leave the room and walk out, they may not be able to understand that you're just in the next room. It's a little bit of out of sight, out of mind going on. And they suddenly become afraid because they don't know where you are. They don't know where you've gone and where you're coming, when you're coming back. Are they confused? Do they just not really know what's going on or what they're supposed to be doing? We'll talk about this a little bit more later, but I see this a lot in terms of, caregivers will say to me, he just won't do it. He won't do it. A lot of times that looks like a refusal to do something, but the reality is they're not really refusing. They're not sure how to do it anymore. So they need a little bit more support in that process. Are they frustrated? Imagine how frustrated we would all be if we could no longer communicate effectively. A lot of times they still understand everything that's going on around them in terms of what's being said or things like that, but they are unable to communicate back out. Is there anxiety? For a lot of our loved ones with dementia, they know exactly what's going on in terms of they understand their diagnosis. They know what's happening to them. They are well aware of the fact that their abilities are declining. So imagine the anxiety that must produce. And then sometimes just simple things. Are they hungry? Are they thirsty? Do they need to go to the bathroom? Some of those simple things. All right. We have to look at triggers related to you as the caregiver. All right. People with dementia are definitely going to respond to what the caregiver is doing. So if you as the caregiver, if you are feeling very stressed and very overwhelmed, then we have to be really careful that you are not projecting that. Okay, that can be really, really hard, right? But we have to do our best to not project that, because if your loved one with dementia can sense that and tell that you are stressed and overwhelmed, they're going to feed off of that. And their ability to regulate that is significantly less. So they may not have the ability to calm down and regulate that. So that has to be on you as the caregiver. Is there a poor quality of relationship? I've worked with people before that, maybe they never had a particularly strong marriage, or maybe it's a parent and child relationship and it was always a strained relationship, and it's still a strained relationship. And so that can certainly affect some of those behaviors. So there may be just a poor quality of relationship. One of the number one factors is poor communication style. And we're going to spend a lot of time talking about communication. And then finally, poor health. Again, person with dementia, yes, but what about the caregiver? If the caregiver is in poor health, probably your loved one is well aware of that, can tell that, and is probably flat out worried about you. So we have to consider your health as well. All right. We have to look at the environment. Again, we're talking about how can we modify the environment. So we really have to look at, are there things in the environment that are causing these behaviors? So is my loved one overstimulated? So for example, am I expecting my loved one to successfully sit and eat lunch when the TV's on and the dogs are barking and the grandkids are playing? Is that too much? And I'm expecting way too much of my loved one to be able to focus on a task when there's so much going on. Are they understimulated? Are they bored? Are they just not engaged because they're not doing much of anything? Are they watching TV all day because we're not quite sure how to get them to do anything? And again, that kind of goes back to maybe it looks like they refuse to do anything, but maybe the reality is they don't know how to do it anymore. And so they need our support to help them do those things. Is there poor lighting? Can they just not see? Can they just flat out not see? I've talked about those visual perceptual issues earlier. That is definitely a hallmark of Lewy body dementia, but we see that with all types of dementia. So if they have those visual perceptual issues, if there are lots of shadows being cast places or there's a lot of glare, then their brains don't do well perceiving the environment. So it may become very scary for them to get up and walk across the room, suddenly becomes really scary. So they may resist doing that. Are they having difficulty finding their way? Do they just not know where they're supposed to be going? Maybe they feel like they need to use the restroom. They have no idea where it is. They can't find it. Maybe if they're kind of pacing the house, it's because they're not really sure where they're supposed to be or what they're supposed to be doing. Is there a lot of clutter? So for example, if you think about opening your pantry door, and if I said, okay, you have 5 seconds to find a can of green beans, go. That's a whole lot of visual information to be looking at. Now imagine if everything looked like that to you. If you're trying to find your toothbrush and you're looking on your countertop and there are, 35 different things sitting on that countertop, it may be really challenging to find your toothbrush if you have those visual perceptual deficits. So then that kind of leads to that frustration. And again, sometimes that can flat out look like a refusal. It looks like I don't want to brush my teeth, or I'm not going to brush my teeth. It may not really be about the person not wanting to brush teeth. It may be about they can't find their toothbrush. They can't see it. They don't know what to do next. So are they too hot or too cold? Again, just sometimes these simple comfort things, really making sure they're comfortable. So maybe we're starting to see a lot of anxiety building, and maybe they're just hot, or maybe they're cold. So when we go to try to investigate the trigger, here's what I want you to do. I want you to look at the behavior. What's happening? What's going on? And this is where I want you to ask yourself, where is this happening? Does it always happen in the bathroom? It's always when we're trying to take a shower. That's when I see this behavior. Where does it occur? Is there consistency about where it happens? When does it occur? That's really important. Maybe it always happens in the morning, and then by afternoon, we're fine. Probably more typically flipped. Probably we're fine in the morning. By afternoon, we're becoming really agitated. Maybe it always happens at 2 o'clock in the morning. When is it happening? How frequently does it occur? Is this something that this happens every single day? We kind of go through the same pattern, the same routine every day. Is it just every once in a while this happens? In that case, you're kind of looking at, is it related to a poor night's sleep the night before? Is it related to we had a lot of doctor's appointments that day? What's the frequency? Looking at who is present when it occurs. Are there people that trigger your loved one? Maybe it's you, maybe it's not you. Maybe it's one of your kids. Maybe it's a certain caregiver. Who's present when this is happening? And most importantly, because this is what we can really change, how do you respond when it occurs? That's going to be the most important thing that you have the power to change, is how you respond when these behaviors occur. Okay. So once we've kind of looked at those things and we say, okay, I think I've kind of figured out some stuff here, that I think that, my loved ones becomes really agitated under these circumstances, this time of day, maybe around this activity, those types of things. How do we even start to address it? Where do we start? Well, I would recommend you work on one thing at a time. So pick one behavior. Maybe it's pacing, maybe it's following you, maybe it's becoming agitated when it's time to take a shower, maybe it's refusing to eat. Pick one thing and let's target that one thing. And the reason we do that is because I can almost guarantee you, if you kind of figure out strategies around that one thing, you're going to be able to apply those to a lot of different things. So when you kind of figure out the right way that you need to communicate with your loved one and set those things up, then you'll be able to magically generalize that to a lot of different things. So we're going to pick one thing. I would say start with the most stressful. What is the one thing that stresses you out more than anything? Probably that shower, or taking medications, or getting them out the door for a doctor's appointment. What's that one thing that really stresses you out? Looking at those triggers and really thinking through, what can I change? What can I not change? Really looking, if we have to go to the doctor's appointment, we have to go. But is it possible that I request a 10 o'clock appointment instead of an 8 o'clock appointment, so we're not trying to get out the door by 7, which is what makes me insane because we can't do it. What can I control? And then when you start to change things, we really want to look at communication strategies. This can be one of the most effective things that we can change, and we're going to go through those. But really looking at how are we communicating. So trying one strategy at a time, then kind of evaluate, did that do anything or did it not do anything? And then modify as needed. I don't predict that you're going to try a strategy one time and be like, oh, that was it, the perfect one. It's going to take some trial and error. It's going to take playing with some different things, trying some different things. That didn't really work. What else can I do? So you may need to try it for a couple of weeks before you start to see a difference, because you're going to have to tweak the way you do things as well. So pick that one thing and play with it a little bit before you move on to the next thing and decide if it does any good or not. Okay, so one more thing about this, kind of like I said in the beginning, that, this can be a bit of a moving target, right? So maybe today it worked beautifully and tomorrow not so much. So what do we do about that? Well, what I would invite you to do is, once you find, okay, this worked today. Okay, this was great. This worked really well today. I'm going to write that in my little repertoire of strategies. Okay. And then the next time you come up with something, go, okay, well, A didn't work today, but I tried B and B actually worked today. Now I've got 2 options. So you kind of develop, like I said, this repertoire of strategies. So then you've got some go-tos and you can go, okay, well, that one didn't work today. Let me try this one. Well, that one didn't work. Let me try this one. Okay, that was the one today. Okay, and because it changes, right? All right, so as promised, let's talk about communication. We can really change a lot with communication. First thing, speak slowly. Understand that their ability to perceive what you're saying has changed. So we want to speak slowly. So people with dementia, they need extra time to process what you say. Okay, so we can't just be throwing stuff at them left and right, and expect they're getting all of that and processing all of that. They need more time to process that. So, I have on here, allow at least 5 seconds after each phrase for them to respond. I need to change that. That is grossly an underestimate. You may have to wait 2 or 3 minutes. You may have to wait with one gentleman I worked with. It sometimes took 10 minutes, and it wasn't a verbal response we were expecting from him. It's, for example, we would need him to open his mouth to take his pills. So it would take 10 minutes for his wife to say, it's time to take your medicine, giving a little bit of cueing here, showing him the pills, and then she would walk away for 10 minutes. And then when she would come back 10 minutes later and cue him again, he would open his mouth right up. He just needed time to process what she was asking him to do and to think through it. If we did it any sooner than that, he would almost become combative, because he wasn't sure what was happening. He just knew she was shoving stuff in his face and he didn't understand what was happening. When we gave him time to process, it was not a problem. So you may even need a lot longer. So don't be afraid to play with that. Don't be afraid to try, okay, I did 2 minutes today and that still wasn't enough. Then I'm going to try 3 minutes. Let's figure out what that magic number is. Okay. You want to address the person by name. And if we get to a point that there's a little bit, especially like thinking about in the middle of the night, if there's confusion and stuff like that, please don't assume that your loved one automatically knows. If there's a little bit of confusion and frustration during the night, don't be afraid to say, honey, it's Laura, your wife. I'm here with you. Don't be afraid to do that. It may feel strange, but don't be afraid to do that. We want to use simple verbal commands. So this is where I say that the person, it may not be a refusal to do something. It may be more, they don't know how to get started. They don't know what to do. So we may need to break everything down into very simple steps. So we want to use very specific verbal prompts. And the biggest take home here is to avoid abstract. So if you say to your loved one, you need to go brush your teeth, or it's time to go get dressed, then they may go, okay, I will. And then 20 minutes later, did you brush your teeth? No. And then that's frustration. Well, why? Why are you refusing to brush your teeth? May or may not be refusal. It may be that they have every intention of going to brush their teeth. They don't know how to get started. What do I do? Where do I go for that? How do I do that? I don't know. I don't know how to make this happen. So it may be that you need to break it down into very specific commands. So instead of get out of bed or go get dressed, we're going to say, okay, sit up. Okay, put your hands right here. Okay, put this shirt on. So we're breaking it down. Okay, so instead of this very general, here are your clothes, get dressed, we may have to break it down even more and say, here's your shirt, put this on. Here's your pants, put these on. Maybe even more so. Maybe here are your pants, let's put one foot in. Okay, let's put the other foot in. So if you're seeing that there's a change in their ability to do something, or even just in their willingness to do it, try breaking it down even more and see if you can simplify it even more. All right. Give simple choices. All right. One or two concrete choices, or I'm sorry, 2 or 3 concrete choices. Really 2. Okay. I just went through this with my students, and my student, who's a private caregiver for someone, emailed me over the weekend, and she said, oh my gosh, she said, I've been caring for this lady for a long time. She's losing weight because she won't eat, because this is how it's presented. Are you hungry? No. Are you hungry? No. Are you hungry? No. Guess what? You're getting an automated response, right? Of no. That's too abstract. Are you hungry is way too abstract. All my student did was take my suggestion, and instead of saying, are you hungry? She said, do you want a hamburger or do you want a piece of pizza? And lo and behold, she's like, pizza. And now she's eating. And so now, you know, the family and the student, they're all going, oh my gosh, she's been hungry this whole time. So again, the difference was we didn't give her this abstract question. We gave her a very concrete question with 2 choices. Okay. Something to consider on that. More than likely, they're going to pick the second one because that's what they hear last, right? So if you say hamburger or pizza, they're probably going to pick pizza. If you say pizza or hamburger, they're probably going to pick hamburger. Probably going to hear the most recent thing. They're going to choose the most recent thing they've heard. Not always, but sometimes that can happen. So just something to kind of observe about that, because if that is the case, then we want to make sure that, you know, if we need to guide, like if we really need them to get some protein and that day they haven't had much protein, either offer 2 protein options or make sure what we need them to take is the second option. So, but again, it doesn't matter. That's irrelevant whether they are really choosing A or B. The point is we are empowering them to be part of that decision-making process. So very important. And we realized that, okay, she actually was hungry. She just didn't know how to answer this abstract question. Okay. So again, we want to avoid things like, what do you want for breakfast? We want to give choices. Would you like eggs or would you like toast? Use encouraging language. Be supportive. Say things like, take your time, or you're doing a great job, or just that reassurance of everything is okay. I threw in the you smell so nice because I like to use that when, you know, when we're really trying to encourage grooming and oral hygiene and showering. Boy, just that positive reinforcement after a shower. Oh my goodness, you smell so good now, or you look so nice, you're so clean. Really giving that positive reinforcement. If your loved one likes touch, then by all means use touch. You know, hold hands, rub their back. You know, whatever it is that makes your loved one feel secure and supported, if that's something that they have typically enjoyed. Okay, here's a big one. We're going to avoid negative approaches. Number one mistake I see people do is trying to rationalize or reason, right? Some of y'all are smiling. Y'all know I'm talking to you. So trying to rationalize or argue or explain, well, this is why you have to take a shower, or this is why, you know, this is why I need you to eat this, or this is why I'm trying to rationalize, I'm trying to explain to you. At a certain point with dementia, that does no good anymore. It really does no good. They are not able to understand what you are trying to rationalize to them. So all that's going to do is cause frustration. Okay, especially if they are arguing back and saying, no, that's not right. No, that's not right. In their minds, they are perfectly justified in what they are saying. You're not going to change their mind. So all you're doing is causing more frustration. So just try to avoid arguing. Try to avoid logic. 100% of the time, avoid scolding. You know, these are adults, and we want to avoid things like, you know, we don't want to say things like, I told you to put the other shirt on. Why are you wearing that shirt? You know, we don't want to scold. We have to monitor our anger, not saying that there won't be times that you feel angry and frustrated and stressed. Of course you will. Absolutely. We want to try to not project that onto our loved one. We don't want to make fun of somebody, if they come out wearing two different socks or two different shoes or whatever it is, we want to avoid making fun of them. Now, of course, for some of you, you have very good natured relationships with your loved one, and that's okay. If that is the nature of your relationship and your loved one still thinks it's funny, that's a different story. But if it seems to frustrate your loved one or make them feel insecure, then we want to avoid that. We want to avoid highlighting the mistakes. All right, let's talk about nonverbal communication. So never underestimate the power of your body language. So if you're saying, it's okay, dear, but your body language is going, it's okay, dear. Okay, they pick up on that. They absolutely know, and that's going to cause them to feel stress. So don't underestimate the power of your body language, both directions, whether you're feeling stressed and frustrated, but also the importance of that gentle touch to reassure that person with dementia. Okay. We want to make eye contact, but avoid staring. If we're going to give them 2 or 3 minutes to respond, we don't need to maintain eye contact for 3 minutes. We don't need to, do this trying to, because that can make them feel very uncomfortable because they know you're expecting that response. So make eye contact when you present the question or present whatever you want to say, and then it's okay to back off and give them a little bit of space while they process that information. You want to position yourself at eye level. As dementia progresses, people's ability to perceive the world around them diminishes over time. So right now, for a person who does not have dementia, we can perceive everything that's going on out here. If we hear a noise behind us, we can probably make some rational assumptions about what that noise was. As dementia progresses, this world diminishes down, till by the end stage, really their world exists. I mean, the way they usually have us do it in OT circles is kind of do this, and that's their world. That's what they see and that's what they perceive. So what does that mean? That means if you're standing behind them talking to them, or you're standing off to the side, you're just noise out there. Okay, they may not realize it's you. They certainly may not realize you are talking to them. So as it progresses, you need to be here directly in front of them to be sure that they perceive that you are actually speaking to them. All right. Use visual cues. We want to point to items. So we want to give them as much cueing as possible. So if we say, honey, it's time to brush your teeth, then maybe pick up the toothbrush and hand it to them or point to it or something like that. You may have to use hand over hand to help them get started. So maybe for mealtime, maybe you're helping them get the fork, getting the food on the fork, and you're actually using your hand to just kind of help them get started. And then once you help them get started, they may be able to continue on their own. Another really good one is to model the behavior you are seeking. So we have these things called mirror neurons. And what those mirror neurons do, they're these neurons that basically, like, for example, my mirror neurons for drinking my Topo Chico are going to light up whether I'm drinking my Topo Chico or not. If I see you reach for your drink and take a drink, those neurons are going to light up in my brain. So we can kind of prime their brain a little bit. So if you're drinking your water or your Topo Chico, while you're also encouraging them to do it, they're going to see you do it. It's going to increase the likelihood that they're also going to do it. So we can use that for brushing teeth and mealtime and things like that. So sit with your loved one in front of them and you eat as well, or you brush your teeth at the same time. So we want to model that behavior that we're trying to get them to do. Okay. So what about their ability to communicate back to us? So the person with dementia may become frustrated and agitated if they're unable to communicate with you. Okay. Allow them time to speak. Try to resist the urge to jump in and complete every sentence for them. That includes when you're at doctor's appointments or anything like that. Try to give them time to speak. Okay, if you're at the doctor realizes this person has dementia. We get it. We understand. It's okay. If your loved one is stuck, you can offer to help. Say, can I help you? I think what you're trying to say is this. Is that correct? But then you also want to confirm that. So for example, you may say, are you trying to say that you need to use the restroom? And then you want to kind of, again, get that feedback. Is that correct? Is that what you're saying? Okay. So you can kind of paraphrase to show them that you understand what they're saying. So bottom line is don't jump in too soon. If you're gonna jump in, you might jump in and just say, is it okay if I try to help you? Or I think what you're trying to say is this. Is that what you're trying to say? Is that correct? If the person also assessing their nonverbal communication. So if there's a lot of pacing or fidgeting or becoming combative, they're trying to communicate something. They just don't know how to communicate it. So again, if they're up and pacing back and forth, you need to think, okay, do they need to use the restroom? What do they need right now? What are they trying to get? You would expect if you're seeing some urgency there, again, maybe they need to use the restroom, something like that. Looking at things like if they're touching and rubbing a certain part of the body or wringing hands, are they in pain somewhere? Is something hurting? Looking at where they're walking to, if they're just going back and forth to the kitchen all the time, okay, maybe they're hungry, maybe they're thirsty. But again, that process of going and getting, they kind of know what the kitchen is, but that process of going to get something to eat or drink, they don't know how to do that. So watch those cues, try to figure out why is that happening. Certainly medical considerations. Person with dementia may experience medical complications, but again, they may not be able to tell you that they're having symptoms of something, especially if it's something, again, something like constipation or urinary tract infection, or maybe they just have body aches. Maybe they're starting to run a fever, something like that, that they aren't able to communicate that to you. You may see that as behaviors. So you have to think about that. Maybe if you're seeing a really odd change, so something's not right, do a quick temperature check. Maybe check vital signs, check blood pressure. Just see, is there something going on? If all of a sudden their blood pressure is really high, that's a pretty good indicator something's going on, right? Maybe I need to give the doctor a quick call, see what we should do. So you have to become the medical advocate and monitor signs and symptoms of these complications. It's really helpful, and I think, I couldn't remember if this was on my next slide, but it is. So, it's really helpful for you to be educated about the medications and some of the potential side effects and interactions. If the doctor's going to put your loved one on a new medication, take a minute to learn about what side effects should I be looking for, or, what are some of the potential interactions. Talk to the pharmacist about that. Ask the pharmacist, say, okay, this is new. Are there going to be any interactions that I should potentially be concerned about? I would advise you not to get it from Google, because you'll think everything's a side effect or interaction, but talk to the doctor, talk to the pharmacist about that. You have to pay attention to fluid intake and the potential for dehydration. You really kind of have to pay attention. How much are they drinking in a day? I love the water bottles that have the ounces marked off on them. Those are great, because then you fill it up at the beginning of the day. It's pretty easy for you to keep track of how much fluid intake there is, because we need to know if they're becoming dehydrated, then there can be a significant risk for urinary tract infection and a lot of secondary issues because of that. A lot of people tend to become dehydrated because it becomes too difficult to go to the bathroom. The process of using the toilet becomes too difficult, so they avoid drinking water. They avoid drinking so they don't have to go. So be mindful of urine and bowel output and watch for constipation or signs of UTI. Just pay attention. When's the last time they had a bowel movement? You know that person's typical pattern. Do they typically go every day, twice a day, every 2 or 3 days? Just kind of be mindful of what their pattern is, so that you can kind of think back, you know what? They haven't gone to the bathroom in 4 days. I bet they're constipated. Maybe that's why I'm seeing pacing and fidgeting. And then signs of urinary tract infection, frequent urination, if the urine smells, is dark and cloudy and has an odor to it. Also, women, there's a lot of itching with a urinary tract infection. So watch if you're seeing that. We also tend to see changes in cognition with any kind of infection. So with urinary tract infection, that's one of the first things we suspect if we see a sudden change in cognition. So we've got their baseline and all of a sudden something very strange is going on. Sometimes that's one of the first things they look at is, could it be a urinary tract infection? Be aware of incontinence. So they may be experiencing a change in continence. So maybe their ability to hold urine or hold or control their bowels is changing, and they are feeling that urgency. That may be why we see some of this anxiety, that they feel like they can no longer hold it like they could. And then, of course, pain. We always want to be on the lookout for pain. All right. It is important that you manage your stress, right? That's very, very important. Because I'm telling you, you have to stay calm. You can't get upset. You can't show any negative body language. You have to do all these things, right? Because your loved one can't regulate this. You have to. All right, that sounds great. How realistic is it? Well, let's figure out ways that it can be realistic. So when you're working through a challenging task, the goal is that you maintain a calm demeanor. Okay, that's that whole important, how do you respond to things? All right, because if not, the person, your loved one may perceive your stress or frustration and react to it. We can kind of get the snowball going, the snowball effect going. And again, they can't stop it. If your tone of voice and body language are becoming more and more aggressive, then your loved one is also going to become more and more aggressive. Okay, so how do we do that? All right, here is the list of amazing, wonderful, gold standard. If we could all do it, great. Find time for yourself. If that's a possibility, please do it. I realize that's not always a possibility, but if that is a possibility, even it's just a few minutes, even if you can get your loved one, to sit down and, okay, you know what? They're going to watch the Spurs game for 30 minutes. Awesome. I've got 30 minutes that I can just breathe and zone out. They're right there still, but I can just kind of, meditate for a few minutes, do something I want to do for myself. Try to engage in activities you enjoy. Again, if there's any way you can get a little bit of respite care so that you can still engage in activities you enjoy, that's great. So be sure you maintain your health appointments. You're taking your medications, you're seeing the doctor, you're doing all the things you need to do to take care of your health. Try to get daily exercise. That can be a walk, that can be whatever it is, but try to get some daily exercise. There are things like Sit and Be Fit on KLRN that comes on every day at 11 o'clock. That's a great thing you can do with your loved one. Their degree of participation, it doesn't matter. If they're participating at all, that's great. That's great. But you can do it along with them and also get some exercise. Maintaining good, healthy foods and good eating habits. And then try to get sleep. Again, I know sometimes that's not always feasible, but try the best you can to get some decent sleep when you can. Try to avoid the temptation to, okay, they're finally asleep, it's midnight, now I can have some time to myself, so I'm going to stay up till 3 a.m, even though I know they're going to be up at 8, because this is the only time I can, just have some downtime. So sleep is extremely important. All right, so now let's get to some of them that you can do in the moment. All right, so to help you relax and to help your loved one relax, use music. Music's one of them. Put some nice relaxing music on. It may help your loved one relax, it may help you relax, or whatever music makes you feel good. Using some visual imagery. These are things that you can do that, okay, my loved one is still right here. I'm still on duty. It's still 24/7, but you know what? They're engaged a little bit in this TV show or whatever it is. I can sit and do some visual imagery. I can vision myself on that beach, with my pina colada or whatever it is, just do some of that visual imagery and try to help yourself kind of find that calmer place. Counting exercises. Going for a walk or doing yoga. Again, you can pull up some simple yoga on YouTube or whatever and sit right there in your living room and just do some very simple stuff. Progressive muscle relaxation and the deep breathing. This is the one we teach in the COPE program. It's so important. If you are in that moment and you feel your stress level clicking up there, stop and just take a few deep breaths. Deep breath, inhale in, hold it for a few seconds, and then exhale it out. Do that 4 or 5 times. And I promise you, it will bring everything down a little bit. All right. The beautiful thing about that, you don't have to walk away from your loved one. You don't have to leave the room. You don't have to do anything. If it's in the car and there's stress in the car, you can stop and do it right then and there. Okay, so remember that one. That's really, really important. It actually has a physiological response in your sympathetic nervous system to calm everything down. So that's a really important one. Another thing to think about is, try to anticipate when you're going to have these challenges. So if, I'm running out of time. If you know that shower is going to be a battle every single time, then go into the shower after having taken some deep breaths and anticipating this is going to be a struggle. I'm breathing. I'm ready for it. I'm in a good place. I'm ready. Let's do it. I know this is going to be a challenge, and that's okay because I'm ready for it. So it's very important to help your loved one maintain consistent routines. So we want to try to keep the same pattern to our day. It doesn't have to be a schedule. We don't have to do 9 o'clock is this, 10 o'clock is this, 11. We want to maintain some consistency and patterns about the way we run the day. So breakfast is followed by some time outside, is followed by some rest, is followed by a little exercise. So that type of thing. So you guys create the routine together. That can be whatever you want it to be. You guys decide that. Base it on what you know about your loved one. I need coffee first thing in the morning. That's going to be something that will always be important to me, to have my cup of coffee in the morning. So the routine should be based on what works for you guys. If your loved one always took a shower in the morning, then that's probably the best time to continue to try to do showers. That's what makes sense to them. That's what works. Consider placing more difficult tasks at a time during the day when your loved one is at his or her best. So again, at the end of a long day when you're exhausted, maybe not the time to try to get a shower in, because your loved one's going to be really tired. So let's do those difficult tasks at the time of day when they're fresh and rested and at their best. Okay, so again, it's not a schedule, and you have to be ready to be flexible with it. It's okay. It's okay. If the schedule doesn't happen today, or if the routine doesn't happen today, it's okay. If we need to modify today, it's okay. So those routines may change over time and they may need to be modified, but that's fine. This is just kind of an example of what a routine looks like. Okay, so again, it's not timed. It's just kind of, this is the general order of the day. All right. And then we want your loved one to be able to try to participate in meaningful activities. All right. Whatever it was that fed your loved one's soul before is still going to feed their soul now. All right. So what are those things that he or she really loved to do in the past, and how can they still participate? Maybe not in the same way. Maybe they were a concert pianist before, and can't really do that anymore. But does listening to classical music still give them that same satisfaction? So to what degree can they still participate in those things? If they were a huge cook before, that was their role in the family. They were the family cook. Okay, probably can't be at the stove cooking anymore, but can they help you plan the rest of the meals for the week? Can they help you pick out some recipes? Can they just be in there with you and you can talk to them about it while you do it? How can we still engage them in that activity so that we're not taking that away from them? We're just changing what their participation looks like. Okay, and relax the rules. Remember, the benefit of all of this is really in the process, not in the product. So if you ask mom to stir the cookie dough a little bit and a lot of it spills, okay, that's all right. It doesn't matter. The point is did she get a lot of joy out of participating in baking cookies for the grandkids? That's the bigger picture. Okay. So, if your loved one was a homemaker and took great pride in participating in cleaning the house, then find ways that they can still do it. Maybe it's wiping the countertops. Maybe it's folding towels or mixing cookie dough. How can they still be part of that process in a safe way? I think I've already used a lot of these examples, but if your loved one was a teacher, for example, then they probably like to organize things and do things like that. So what can we find to let them organize and do things like that? And again, it's not about, did they organize it the way you would have? Did they fold the towels the way you would have? I don't care. It doesn't matter. The point is that they are getting that satisfaction from that participation, and that can affect their behaviors. Okay, so we have case studies in here, but I'm guessing I'm kind of out of time. So we are going to forego the case studies. And Jennifer, how are we doing?
I think we're doing pretty good. I think it'd be great if you could do at least one case study, if you don't mind.
Okay, let me, Okay, I will choose this one. All right. Okay, Mrs. M is an 82-year-old female with Alzheimer's disease who lives at home with her husband. Her children also participate in her care. Lately, she has become convinced that her husband is bringing home other women and cheating on her. She even believes these women are in her bed at night. She refuses to allow her husband to provide any care, and she stays agitated over this issue. Okay, so with this family, the husband was not bringing home other women, and they couldn't figure out why she thought this. As I really started investigating what was going on at home, I said, well, what does your mom do all day? Well, it turns out mom does nothing all day. She sits in her chair and does nothing. She sat in her wheelchair all day and does nothing. So when I kind of started diving more into, well, what did mom used to do? Well, she was the homemaker. Like she was on top of everything. She raised the kids, took them to every activity, cooked all the meals, cleaned the house. I said, and who's doing all of that now? Well, the children were all taking turns coming in and doing those things now. So basically what had happened is they had taken everything, this woman's entire role in life, everything that was meaningful to her in life, everything that she did that brought her joy and meaning had been taken away from her in an attempt to say, no, mom, you don't need to do that anymore. We will handle it all for you now. But what they did is basically they kind of took away her whole identity. She had no more identity. She was just this person sitting in a chair watching as everything happened around her now. And so I think that's where a lot of that came from, was somebody else was doing all of this stuff. So it was kind of she was replaced in a way. What was her role? Where did she belong? What was her role in life? What was she contributing to anything? And again, her kids thought they were doing a great thing for her by saying, mom, you don't need to worry about it. We'll handle it now. But what I suggested to them is, obviously mom cannot do all of this anymore, but what can she do? How can she be part of the process? Even just something as simple as, mom, I'm going to put this load of laundry in now. Should I wash this on hot or cold? Just let mom be part of that process. Let mom fold the towels. Let her fold the socks. As dinner's being cooked, bring mom in and sit her at the table and talk to her about the recipe that you're making. Things like that. Find ways to include her in it, even though she can no longer do those things independently. We also found with her that a lot of times her husband would leave the room and leave her there alone. And remember what I talked about earlier, once he was gone, he was gone. He was not in the next room. She had no idea where he was. And so that caused her a tremendous amount of stress because she didn't know where he was. So what I suggested they try is kind of, with kids, we would call it parallel play. Let's engage her in something over here. You can do your own thing over here, but you're still in sight. She can see you. So she's still doing her own thing. You're doing your own thing, but she can still see you. Or at the very least, if you go into the other room, talk to her, sing, whistle, do something so that she still hears that you're there. Something like that, because when he would leave the room, again, she didn't know, she was scared. She didn't know where he had gone. So when they kind of implemented these things, they saw a huge change in her behaviors. We just included her again. We just brought her back in and included her again and helped her again kind of find her place again. They had taken everything away from her. So that's how we kind of want to look at this. Again, where, her husband insists, he's like, I've never cheated on her in my life. I don't understand. He was offended. He was deeply hurt and offended that she was accusing him of this. But we had to look at where was that coming from? What was causing that? And once we fixed those underlying things, again, we modified the environment around her. We had an effect on that behavior. So, okay. Are there any questions? Do we want to do another one? What do you think?
I think it'd be great to open the floor for questions.
Okay, I'm going to stop my share then.
That's great. And I'm going to stop recording so everybody can feel comfortable asking their questions.